we'll do few slides on male infertility. Uh, Now, this is you can say I'm going to just take you through some papers of male infertility, and this is the way we read our papers. Just to give an example and snapshot how we read our papers, and we make slides as we read our papers. So we can borrow that slide, and at my clinics with PGs or for presentations we use it. So this is coming up quite big nowadays. This is by Sandro Esteves group, who did the group Poseidon. And after group Poseidon, they thought they should have a nomenclature system for, or a good classification of male infertility. And they know good classification of male infertility exists. So they came out with a classification system called Aphrodite criteria. It's the same Peter Humayden and Sandro Esteves group. They said addressing patients of hypogonadism and infertility owing to altered idiopathic testicular function, and they called it an Aphrodite criteria. And this is already published, 2023. And recently in IVI RMA conference, Peter Humayden, I just saw in his LinkedIn profile that Peter Humayden has published his data on Aphrodite classification, and probably that was very well appreciated by everybody. So I think we need to classify our male infertility subjects into Aphrodite, and that's what I'll be discussing this paper with you. This comes like this because this is ahead of press. When I must have read it, it is yet to be published, and that's why it comes like that. But if you go through a paper, now it is published properly. So hormonal treatments of idiopathic male infertility are not yet established. While in females, gonadotropins are universally used in spite of varying etiology of infertility. Such a funny thing, isn't it? Whatever may be the etiology, it is oligospermia for IVF, whatever maybe it is, you are using gonadotropins left, right, center to improvise the female fertility. But we don't use it to improvise the male fertility. Okay, so Poseidon criteria inspired to classify male infertility into subcategories and answer the therapeutic needs of each subgroup. So that's why they have come out with Aphrodite criteria. The goal is to standardize the clinical trials which are published on male fertility. Absence of either FSH or LH does not lead to azoospermia in humans. Okay, and FSH spermatogonia, FSH function is to make spermatogonia into spermatocytes in the seminiferous tubules, where LH just increases intratesticular testosterone and makes the spermatocyte to a mature sperm. But unfortunately, none of your tests measure intratesticular testosterone. We don't measure it electively. Ideally, we should. And FSH is definitely a marker of spermatogorgia stimulation. It's the inverse relation of FSH and sperm. That means if the sperms are less, FSH is more, and FSH is that's what. And FSH is less, the sperms are more. In female hypoc, even if the FSH is less than 2, you will say it is hypogonadotrophic. In males, it has to be less than 1 to say it hypogonadism. Even between 1 to 2 is a normal FSH level for male. So even if the FSH goes to 9 to 12 MIU, there will be more spermatogenic defects. Okay. And in females, you say FSH only going beyond 10 or beyond 12, you say there will be less number of eggs. Normal FSH in male is 1.3 to 8.4. Remember 8.4. Beyond 8.4, the spermatogonia will be less, and normal LH is 1.6 to 8. So testosterone, serum testosterone may represent intratesticular testosterone, but is not an accurate measure. And actually, the accurate measure is 17 OHP or AMH level. That is an accurate measurement, but neither we do AMH in males, neither do we do 17 OHP. So if you want to treat somebody with hormones, I think you should be doing 17 OHP. If the husband is insisting that I would like to have conservative treatment, do a 17 OHP. A threshold testosterone level is 350 nanogram. And testosterone normal is about 450 in normal men and non-obese. And median testosterone level is, they said, 698. I don't see such high testosterone levels in Indian population. With obesity, there is increase in estrogen. Even if the estrogen goes to 60 picogram in husband because of peripheral conversion of obese cells, FSH will drop down. FSH drops down. That's why even the testosterone secretion will drop down. So testosterone will be low. So with testosterone, there is something called low testosterone. A low testosterone means any level less than 350 nanogram. And there is something called testosterone deficiency. That means having low testosterone with androgen deficiency symptoms like muscle weaknesses, fatigability, etc. So Aphrodite group 1 is a hypo patient, a hypogonadotrophic hypogonadism. It could be acquired or congenital. Acquired could be because of anabolic steroid use. There are a lot of gentlemen who go to gyms, they use those protein preparations which are commercially available on Amazon. They may be having anabolic steroids. Or they could be because of a disease infiltration of pituitary, excessive exercise, tumors of pituitary, alcohol excess, sarcoidosis, etc. Obviously, because of hypoc, FSH is low, LH is low, and so is testosterone. HMG, so obviously we are basically doing FSH, LH, testosterone to pick up your hypoc client. And if you can pick up a hypoc client, it is real winner because then you can treat it up. The treatment will be giving HCG, FSH, but we don't give FSH alone. It is always FSH and LH. So we prefer giving HMG and HCG are the mainstay of treatment. Generally, we start with giving HCG. I generally give 5,000 IU twice a week for about 2-3 months for the testosterone to come up. Once the testosterone comes up, then you can add FSH or HMG with HCG, and that can continue. But nowadays, I don't wait. I just start them on HMG and HCG together, so that. But they will require therapy. Anything around 6 to 9 months of therapy will be needed. HMG is 150 IU 3 times a week, and HCG 5,000 IU once a week or twice a week you can use. So that's the therapy we give. Aphrodite group 2 is low semen but normal FSH and testosterone. This is the commonest oligospermia you have. You have oligospermia. The semen is oligospermic, but testosterone, FSH, LH, everything is normal. This is your idiopathic oats, or sometimes it could be a non-obstructive azoospermia with a normal FSH because the inhibin secretion is very good there. And normal serum levels may be in. So the interpretation is normal serum levels of FSH-LH or normal endogenous secretion of FSH-LH is inadequate to have a good spermatogenesis. That's the interpretation here. Okay. With that, that means there is a receptor polymorphism. As the receptor polymorphism exists in females, it also exists in male. We can't have, there is no receptor polymorphism in male. So if you can increase your FSH dosing and level of FSH, probably the spermatogenesis will be normal. So Sandro Esteves did a meta-analysis before this, and he said that FSH therapy improved natural or ART results. He looked at all the trials. Whichever trial published on FSH therapy or male, they have improved results. And odds ratios have been 2.4. So surplus FSH compensates for the weak action of endogenous FSH because of receptor polymorphism that is weak, that will overcome. And FSH treatment can be used for eugonadal non-obstructive azoospermia also and patients with normal FSH. And if there is a non-obstructive azoospermia, it is better to give pre-treatment with FSH and then do the biopsy. Your chances of sperm recovery are better. What FSH? If the patient is affording use like FSH, no doubt, or otherwise simple HMG, again 3 to 4 months of therapy would be needed. And is there a parameter of success? AMH level could be a parameter, or you can do 17-hydroxyprogesterone. 17-hydroxyprogesterone goes up, that means you are improved intratesticular testosterone. If the AMH comes down, that means you have improved intratesticular testosterone. That's the way you can monitor. Aphrodite 3 is low semen parameters in normal FSH, but testosterone is low. So this is men exhibiting reduced FSH action because of, again, genetic polymorphisms. HMGs are better since in these patients you can give HMG injections. So biochemical hypogonadism and the histopathology of maturation arrest is the best candidate for HMG treatment. So this, again, we have just testosterone is low, FSH-LH is normal, and there is oligospermia. Well, you can still use your idiopathic as well as this Aphrodite 2 and 3, both come in the same category where you can use your HMG therapies to improvise the count. 4 is low semen, oligospermia, but elevated LH FSH. Now, this is where you are going hypergonadotropic hypogonadism. This is like going towards testicular failure. So, even if the FSH level is beyond 8, it is a sign of testicular failure. So be very careful on that. The endogenous gonadotrophin are definitely inadequate here, and you can still give FSH therapy. Again, like we talk of poor ovarian reserve patients, the FSH is 14, 15. What Dr. Goody said, increase your FSH dose in a therapy. Similarly, the same applies to these men. You can do that and you may get some benefits. Not always, but you can. Aphrodite 5 is unexplained, completely unexplained. Everything is normal. And then we really don't know what to do. Female partners receive controlled ovarian stimulation than male, and the male being is not treated at all. And Then the concept is, can you give FSH therapy to the male of idiopathic completely? Yes, you can. If giving FSH injections to females increases the number of follicles, how can you say that FSH injection to the males, normal females, giving FSH injection to normal females increases number of follicles? How can we say that giving FSH injection to normal men will not improve spermatogenesis? Then if you say, no, it doesn't act in the male, then FSH will be the only hormone has gender-specific actions. Not possible, isn't it? So all Aphrodite is saying is push in therapies with HMGs, FSH and HCG for your patients with oligospermia. Few of them will get benefits. So there could be OHSS in women, but there is no OHSS in men. The testis is not going to increase or burst or something like that. So nothing happens. So you can safely use any amount of HMG, FSH therapy for male without any problems. Suppose you diagnose azoospermia. How do you diagnose it? You have to centrifuge the sample first, get a pellet, and evaluate the pellet at 400x magnification. If you don't see a sperm, then it is azoospermia. So not on a simple semen analysis. This is called extended semen analysis. And scriptazo, if you see in the pellet a few sperm, that's scriptazospermia. Necrospermia, less than 5 million motile sperms, and oligospermia is less than 15 million. That everybody knows. Now, so this is a nice paper. This is a paper on testicular histopathology, semen analysis, FSH, predictive value of sperm retrieval, supportive counseling in a patient of reoperation after TC. So you have done TC and probably you have not got anything or you got something and you want to do a reoperation after TC. And there were about 430 non-obstructive azoospermic that had gone TC, undergone TC, 53 severe oligospermic, and they underwent conventional TC and nothing was obtained. So what do you do next? Now this situation should never arise in your practice. So when you're doing biopsies for NOA, your biopsy should be so thorough, the reporting should be so thorough that reoperation is not going to get you anything. Okay, let's talk of this. So the successful surgical retrieval of the sperm and no surgical, so we looked at the parameters. In whom it was successful? When the FSH mean was 15, FSH 20 and above, it was not successful. See, look at the diagnosis. Diagnosis SCO, Sertoli cell only syndrome. Successful was very, very less. Maturation arrest, better success. Hypospermatogenesis had the best success. So my take is the next paper which I am presenting to you. This situation of reoperation should not arise to any of your clients. You should counsel of repeat surgery. You are telling them, you have non-obstructive azoospermia. I am going to do a TC for you. I will do bilateral TC. My TC steps are so and so. At the end of TC, I don't get sperm. That means you do not have sperm. You don't have to go through one more procedure. Now the patient shifts to urologist. He says, what? He's not given any report to you. How is he sure about there are no sperm? I want to do one more biopsy. So the mistake here the gynecologist is doing is we are not giving a histopathology report. Okay, if the histopathology report is associated with a negative TC report, then the urologist is convinced. He said, well, you are a Sertoli cell only syndrome. I'm not going to get anything here. You got it? So that is one scenario. So let's go to the next paper. Yeah, one thing. You can do a histology of the biopsied specimen, can be done. Entire tissue can never be analyzed, etc. But look at this. This I am putting because extended culture in the sperm in laboratory is possible. So you can plan your TC on a previous night also and keep the tissue in the culture condition, and the sperm is still obtainable for that. I'll go to that paper a little later. This is one paper in between. Probability of sperm recovery in non-obstructive azoospermia presented with TC, volume less than 10 ml and FSH. So they classified into NOA1 group, the FSH was beyond 20, volume less than 10 ml. NOA2, FSH less than 20, volume beyond 10 ml. Okay, they wanted to know what is the significance of surgical sperm retrieval. In both the groups, they got sperms. Okay, in NOA1, in spite of FSH being high, volume being low, 23% you got sperm and 32% in NO2. So the conclusion is FSH level is no way indicates if the normal sperms are not there at all. Like you say an FSH of 30 in females, you'll say probably you're not going to get anything. But remember, the women, the number of eggs always keep down. the sperm spermatogenesis is throughout life, new sperms are formed. Okay, so even if the FSH level goes up, the testicular volume comes down, it is a global picture. Local picture, focal spermatogenesis can exist, and your MTC should be able to give you that focal spermatogenesis. So do not discourage your patients of low testicular volume and high FSH that you won't get anything. You make an attempt. Obviously, you can have a testis which is 1.5 centimeter diameter and FSH is 40. You won't get. It's a fibrotic testis. Okay, but a reasonably good testis, anything beyond 2 centimeter diameter, okay, and FSH level, whatever FSH level, you should be able to get sperms. In a few of these cases, at least 20-30% you'll get sperms. Now, this is the paper which I want you to practice. Histologic effects of testicular sperm extraction. What this paper did is, they said that, sorry, 1 minute, again I'm doing a mistake. Yeah, sorry, this is the next paper I want you to practice. But this is paper I want you to be included in your counseling session. The patients ask you, you're going to do a testicular biopsy, will it harm me in the future? So the answer is yes, it will harm you in the future, because it will harm. One testicular biopsy may not make a huge harm because you are breaching the blood testicular barrier. The moment you breach the blood testicular barrier, your germ cells will be exposed and you can have hypospermatogenesis in the late future. You can have hypoandrogenism also future. So you can tell them, you go through a screening protocol, we do a biopsy, but if they have undergone 2 or 3 biopsy attempts, in that case the deterioration of the testicular function will be worse. With one, you can tell, if you have these symptoms like muscle weakness or general weakness, you should come to us. But what I found is, moment you sensitize them, in 3 months only, they'll come back to you saying that I have muscle weakness. The parameter would be testosterone level. If the testosterone level starts dropping less than 350, then you can start treating them. Otherwise, you don't treat them. Or you'll do a testicular scan to find out, are there any hypoechoic areas, are there any focal calcifications, etc. If anything of that is there, then you say, okay, well, the injury has been inflicted. Now, this is paper I want you to practice. See, what happens is, if an NOA patient goes to a urological cabin, what will they do? They will just do biopsy. Will they preserve the sperm? No. If they come to a gynecologist cabin, we'll do TC, but we will not do biopsy. So see to it that if you are doing an NOA patient, non-obstructive azoospermia, first non-obstructive azoospermia is diagnosed with high FSH and lower testicular volume. Recently, we had an obstructive azoospermia, came to us in Jahangir Hospital with a FSH of 6, normal testis with an ultrasound report saying one of the diameter 4 centimeter, but everybody counseled them that you have a non-obstructive azoospermia, you have to go for donor. So a non-obstructive azoospermia you will diagnose only when the FSH is high. Okay, otherwise there is no point in non-obstructive azoospermia. Very few patients of NOA will have a normal FSH, very few of them, where the inhibin secretion is still maintained by few cells, in few germ cells there, but otherwise the FSH will be high and the testicular volume will be smaller. So our protocol of treating non-obstructive azoospermia is we'll do FSH, LH, testosterone, estrogen. Okay, we'll also do ultrasound to know the test size of the testis and if there is no associated scrotal pathology. We will do a 17-hydroxyprogesterone. If it is low, it's more so indication. Then we'll put the patient on injection of HMG, HCG once a week and HMG alternate day for a period of 3 months. At the end of 3 months, we will tell them to go for a biopsy. Not all husbands are willing to take injection. They are willing to give injection to the wife, but they are not willing to take injections themselves. In that case, we'll put them onto clomiphene, 50 milligram a day, not 25, 50 milligram a day for a period of 3 to 4 months. Why 3 to 4 months? Because it takes 72 days for the sperms to form. And then after 1 month of clomiphene, we will repeat FSH level and see that the FSH level has gone up beyond his basal level. That means the dose is acting well. If it is not, then you will have to still give HMG injections to take, because the whole idea is to push the FSH level high. If a treatment has to push it, then only the sperm count can increase. And then we do a biopsy. The biopsy is divided into 2 parts. A small part is sent for histopathology and small part is evaluated by embryologist to find out sperms. The histopathology can be of 3 types, 4 types: hypospermatogenesis, maturation arrest, early or late, and 4th is Sertoli cell only syndrome. In Sertoli cell only syndrome and early maturation arrest, your yield of sperms will be less. In patients with late maturation arrest and hypospermatogenesis, there is higher probability of you yielding a sperm sample. Obviously, all these NOA will also undergo Y chromosome microdeletion test. If it is AZBC positive, then they can get sperms. But A and B, the likelihood of getting sperm is less. You understood what is the protocol of that, okay? So I'm not going to go through this. Yeah. So we have to have an optimal intratesticular testosterone, which will vary in individuals, and ITT deficiency can cause NOA, which may be improved by hormonal treatments. So if the serum testosterone beyond 250 nanogram is there, though it is low, you can have some good sperm retrieval. AMH, IGF-1 and 17-OHP correlate with ITT. I am not yet doing AMH in my practice. I am not doing it, I must confess. 17-OHPs we do, though infrequently, yes, we do it. Now, who will benefit from FSH treatments? Oligospermic with normal serum FSH level, if there is an FSH receptor polymorphisms, and you can give 150 to 300 alternate day for 4 months. Due to high FSH level in NOA, now this is something thoda barabar se 1 minute. 1 minute, I'm not going to go through. Yeah, let's do this paper. The nice paper, hormonal therapy for non-obstetrical azoospermia, basic and clinical perspectives. So they said that when you do MTC, you are seeking a sperm, but you are not making a sperm. That has to be explained to the client. I don't do MTC, though we have bought microscopes and everything, but there's no patience for us to do MTC. We do conventional TC, but we take a larger chunk of samples. We take a larger sample, and there is paper published on that MTC is more detrimental. It's a horrendous procedure. You have to take a vertical big incision, you have to take a circumference incision on the scrotal tunica, you have to expose the whole seminiferous tubules, then look for microtubule. The procedure can go for 1.5 to 2 hours also, and quite a laborious thing. I prefer taking a cut and taking a larger tissue of seminiferous tubules and submitting it up. And all the counselings of donor, this is all done. You get once in a while a client who is insisted, I don't want my own sperm only, then probably I'll involve some urologist or somebody. But even they are not greatly, we don't get very greatly trained people doing MTCs to us. Yeah? So androgen receptors are intensely expressed and in Sertoli, not serotonin, Sertoli cells, and they are proximity to the germ cells. Increasing ITT shall increase spermatogenesis. Serum testosterone and FSH levels do not reflect intratesticular testosterone and focal spermatogenesis. I told you it's a very global picture otherwise. ITT deficiency can cause, which may be improved. So clomiphene 50 milligram a day can be offered. You can serially increase the dose also, and you can take the testosterone levels very high. And then MTC yield can be increased. So before doing TC for NOA, please give some medical treatment. Then you can avoid a repeat TC later, or not, because patients are not happy if they not got a sperm. They will take one more opinion, and there are 1,000 people doing surgeries in this world. Fertile men should have a testosterone estrogen ratio of 14, beyond 10. That's normal. But if sometimes the non-obstetrical azoospermia, they can have a TE ratio less than 10. When it is less than 10, that means your estrogen is high. Or if you do, we always do FSH, LH, testosterone in estrogen. If the TE ratio is beyond 10, the treatment of choice is clomiphene, because we want to increase the FSH and increase sperm. If the TE ratio is less than 10, that means your estrogen is high. That is causing FSH suppression. So the treatment is letrozole. So we'll give 2.5 milligram OD letrozole for 4 months, suppress the estrogen level. So patients, especially of diabetes and obesity together, will benefit with the letrozole therapy. Daily for 3-4 months. Now this is something, it's a little difficult concept to understand. FSH-LH receptors are downregulated because of persistent high FSH and LH. This is understandable. This allows resetting of FSH-LH receptors and resting. The Sertoli cells and Leydig cells undergo a rest period. They are resting because the receptor is desensitized because of high levels of FSH-LH. थक जाते हैं occupy करके, whose function then improves. Because they are resting, the cells improvise in their function. They are hungrily waiting for the FSH being upregulated, and they want to work. So now you start a treatment with HCG and FSH. This will increase serum testosterone levels. It's a difficult concept to understand, but what is resetting mechanism? The it is said that stimulation of Leydig and Sertoli cells is paradoxically weak due to high gonadotrophin level downregulation. So you have high gonadotrophin levels, receptors are occupied. Receptors are occupied for a long time, so the receptor gets tachyphylaxis, let's say, it gets desensitized. Now, Sertoli Leydig cells, the receptor is not active at all, they are quietly sleeping, so they are accumulating energy and accumulating their hungriness to produce and do their function better. Now you suddenly increase the level of FSH-LH beyond a certain level, and they say that this can awaken these Sertoli Leydig cells. That's how the concept, the hypothesis they have put forth. So this is what they have recommended. So they had patients with failed micro-TC first attempt. They gave HCG for 3 weeks, 3 months. After 3 months, they did FSH levels. If the FSH went down after HCG treatment, FSH was still down, they added FSH and continued HCG. If FSH was normal, they just continued HCG and they attempted second micro-TC. The patients in which the FSH was down, they added FSH with HCG and they did micro-TC again. And look at that, about 20% of them, they could find sperms after the first failed attempt. So why not do all this before you do the attempt? That's what my argument is. So this is what it is. The moment you start giving LH-FSH therapy, okay, the FSH level may drop, but you add FSH-HCG later and sperm and intratesticular testosterone will increase and your chances of sperm recovery is better. So think what I'm giving a message is in NOA, evaluate FSH, LH, testosterone, estrogen, 17-OHP. Start therapy, again evaluate, and after therapy for 2 to 3 months, then do a biopsy. You have done justice by doing that biopsy because you not kept a loophole for a reoperation there. Okay. So this is what, if you're on when do biopsy, always do histopathology. And this is the histopathology advised later. If it's hypospermatogenesis, late maturation, well, you can do all these things. Early maturation arrest, difficult. Developing an FSH hormonal therapy, you can give it, but difficult. Sertoli cell, well, it doesn't make much of a difference. You're not going to get anything more being the second thing. So what is been recommended is second, my request is to do it in your first biopsy itself, prior to your first biopsy. AMH in sperm retrieval. So we are looking for some external predictor, hormonal predictor, which can tell us beforehand that आपके biopsy में मिलेगा या नहीं मिलेगा. What is that? That is what we are looking for. So reliable biomarker needed for successful sperm retrieval, they say. AMH is secreted by Sertoli cells, like granulosa cells in females, in embryogenesis to regress Mullerian ducts. With puberty, as Sertoli cells mature, AMH drops. With granular cells mature, it becomes pre-ovulatory follicle. The AMH expression drops, with FSH action starts. Similarly, as Sertoli cells mature, the AMH will drop. Okay, so AMH is exclusively from Sertoli cells. So if AMH goes down, that means you have a good intratesticular testosterone. AMH doesn't come from any other cell. It only comes from Sertoli cells. That means Sertoli cells are functioning better. That means Sertoli cells are doing well and your intratesticular testosterone is going to go up and AMH obviously paradoxical. Same, you apply the female physiology here. Only instead of granulosa, think of Sertoli cells. Understood? Okay. So AMH now becomes, this is from embryologist, I took it. You can take a picture of that. How do they do a sperm identification of micro? This for my embryologist, I put it up. I told them whether you are doing the same method. Okay. This is how, materials and methods can change your laboratory work. So when you read a paper, read at materials and methods, that will tell you how to do it. So surgical exploration, so we need a reliable marker for sperm retrieval at TC, because if you do surgical exploration, that breaches the blood testicular barrier and there could be side effects. And mean sperm retrieval positive AMH is 2.4, while no sperm obtained when the AMH mean is 5. So this is the AUC. If your AMH level is less than 4 nanogram, it's a positive predictor of sperm retrieval. So now you got another predictor. So you can reassure your client that your AMH is low, I'm hopeful you'll get something. Your AMH is high, I doubt if I get something. You got it? So this is the way you're going to do all your pre-counseling for NOAs. HCG-based hormonal therapy for intratesticular testosterone levels and DNA synthesis. They give 5,000 IU of HCG. I put this paper up because the dose, look at the dose. They give 5,000 IU 3 times a week. Men with high FSH after 3 months continued HCG for another 2 months. Men with FSH drop, they were started with rec FSH also. And they do biopsy, but at biopsy you get some testicular fluid. In the testicular fluid, they did testosterone level. So they did measure intratesticular testosterone and testicular fluid, and they said with HCG therapy it increases. But look at the doses. Don't give primitive HCG therapy of 2000 IU once a week, Indian brand, just be giving 500 IU totally, and 4 mahine ke baad nothing is there. Okay, give an adequate dose, and then possibly this could be true. Okay, what is this? This paper is, yeah. Now, what could be, suppose you commonly get blastocyst, no blastocyst form, and the patients eat your brain up, isn't it? Why am I embryo arrested? So you say, I really don't know why the embryo arrested, and I don't know how to evaluate this also, because which genes were exchanged by the sperm to your egg, and what ultimate formation of genes was there? Was there a mistake? We really don't know, and nature commonly does mistakes. But this sentence is not agreeable to them. And they ask you further, what next are you going to do? You said, well, I'll use calcium ionophore medias. Am I right? You use oocyte activation medias, and you can use a sperm sorting method. You will change the sperm sorting method to hap select, your hyaluron-based selection. The hyaluron-based selection is available two types. Surface hyaluron-based, that's your pixie plate, where hyaluron is impregnated there. And solution hyaluron-based, that is your microfluidics. In the fluid channel, the hyaluron is dissolved in it. So why not do both the things for every patient in first go? Thought about it? We do it routinely. In our hospital, we do calcium ionophore cult active for every patient, and every patient is hap select. So when they come to us with blastocyst failure, they said, we have taken all that care, we have done all that. In spite of that, there is no blastocyst. I can't go and bang another 5 IVF centers. They are going to say, well, everything is done. Because we are in a competitive world where other people are just at a stone throwing distance from us. Okay? So there are bulldozing us probably, not stone throwing also, bulldozing us. They would like to bulldoze you. The competition is so bad. So we prefer doing cult active. The problem with cult active is a few papers are saying there could be an epigenetic change. So I have not yet read those papers up. I will be reading it. But our embryologist started a PhD topic on that we will be doing sibling oocyte cult active study we are doing now, whether it really improves the blastulation rate. The cult active media or calcium ionophore media is specifically recommended for TC samples, severe oligospermic, previous failures, repeated miscarriages, etc. We are using it universally, but now we are doing a sibling oocyte study. Probably down 6-7 months we should be able to give you a better information. Varicocele. Shall I continue with 2 more slides? Is it okay? Or we stop? If you have an azoospermia and varicocele, treatment of palpable varicocele may get sperm and ejaculate, so you treat it up. If you have a palpable varicocele with azoospermia, treat it up. Don't promise them the sperm will come, only a sperm retrieval will improve. So they give 255 men respond in 1 year till ICSI is needed. But this a few patients, it's not 250, it's 25% men. After varicocele surgery, they could find sperm in the semen. Okay, in NOA patients, so they could avoid MTC. Once sperm are there in ejaculate, elective cryopreservation should be done, because relapse of azoospermia is very common in these men, and benefit unlikely in patients with Y chromosome microdeletion. But you will not be able to avoid MTC in all patients of NOA after varicocele surgery, and you should do a testicular biopsy and find out the histopathology. So make it a norm. Whenever you do testicular biopsy for non-obstructive azoospermia, half the sample goes for histopathological evaluation. Don't send minced sample for histopathology. The histopathologist is totally confused. He wouldn't report it. He needs a good sample. So always send sample for histopathological reporting. So NOA varicocele, what counseling you will do? That the hypospermatogenous maturation arrest is seen in 54%. They may improve. 13% patients achieved spontaneous pregnancy. Clinical pregnancy in repaired and non-repaired group same, but one study by one of the authors, I can't even pronounce that name. I had to correct autocorrect 2-3 times to write it that also. They had 74% clinical pregnancy rate. So NO with clinical varicocele, this is the flow of events. Okay, whatever you do genetic testing, that Y chromosome, if it is there, that means you're not going to get anything. If that is done, you go, if it is abnormal, you will go for genetic counseling and donor. If it is normal, you can do a micro TC and go for ICSI. If the genetic counseling is abnormal, it's an unacceptable risk, again donor. If it is acceptable risk, you can still do micro TC. But if it is normal, then you look at the female partner. This, according to me, is the most important step in the whole story. Where is the pointer? Forget it. This is the most important step. This. Okay, there is no point advising varicocele repair with somebody who has an AMH of 0.7 and they can't wait for 1 more year. So see to it that the female partner has an adequate ovarian reserve and young. She is 36 years, you are taking varicocele repair, she is going to become 37, her aneuploidy percentage is going to go up. I don't think you are doing much difference, you might as well hurry. So in men infertility, the female decides as usual to what kind of therapy is needed. Okay? And this is a systematic review, and it says, well, it does, the papers, most of the papers are saying that odds rate or pregnancy rate does ratios improve, even the live birth is better. So in an indicated case, we have varicocele, good female fertility prognosis, there is nothing wrong in doing it up. The problem is our urologists want to do laparoscopic varicocele ligation. Okay, stupidest procedure ever, stupidest. Okay, no results. Okay, so don't encourage. They should do inguinal microsurgical, means under operating microscope, a varicocele repair, and the mean arterial pressure should be kept at 100. If the mean, they have given spinal anesthesia, patient is hypotension, 90 systolic, you are doing varicocele repair, you will miss half the veins. So the mean arterial pressure has to be 100. And preferably use a Doppler in the inguinal, intra-op Doppler should be used to identify the venules and then ligate it. If you do all thorough surgery like this, you get these results. If your surgical treatment itself is faulty, don't advise varicocele surgery. Go for ICSI and be happy about it. Okay? But surgical technique is very important. If they are not following it up, forget about it. In my hospital, varicocele repair last 5-6 years, I have not done a single. NOA, we see almost maybe every 2 days we'll be seeing in one NOA. But varicocele repair is not something I commonly practice because these kinds of varicocele repairs are not done in Kolhapur. No, I'm not going to go through these papers. So this was just a glimpse to tell you, my whole agenda was to convey you, was not more than male infertility, my agenda was to convey you how reading research papers can help you change your counseling methods and how it can change your practice of infertility. That was the whole agenda of putting these papers up. We could have done male infertility in another format, causes, pre-testicular, post-testicular, intertesticular, etc., etc. But that doesn't give you anything. So keep reading. The moment you read, assess if this methodology can be applied into my practice. Okay? And with this ethos, we will be starting a journal club meeting. So give us about 15-20 days. We will announce a journal club meeting. It will be on Friday evenings, maybe at around 9 o'clock in the evening. Okay, 9 p.m. on Friday. We will be having a journal club meeting. Initially, for few journal clubs, we will prevent our own fellows and we will go through papers. But we would like people to volunteer, and we'll push the papers to you. And we can have an internal discussion with Sharyu, me and my fellows, what exactly needs to be presented of this paper. And I'm going to have Dr. Anil Gudi, Dr. Amit Shah, and Professor Gerard Conway. One of them will be joining the journal club every time. So we'll have one expert guiding us how to read a paper, what inferences should be sought, and how valuable it is. And then you will realize the beauty of it, that one paper will lead to reading the next paper, leads to reading the next paper. You know, like I showed you that Irani et al. Paper of LH and E2 and how to identify which is the LH surge. So it commonly happens, give Sharyu a paper, Sharyu pad lena jara. And then she said, I'm not completing it for 3 days. She has completed the first reading in 1 hour, but then she's looking at bibliography, why this fellow said this sentence, reference number 23. She will look at 23, they go back to, she digs out that paper. So one paper reading leads to reading 5 papers because we want to understand why this sentence is put and what reference are they quoting. So when we said that person put, that reference paper put 3 nanogram as their cutoff, but they had not have a reference number. There was no bibliography. So we could not search why this 3 nanogram ever came from that gentleman. So that helps us dive into basics more and more. So you keep digging out papers as you go past. Why this concept? Why this author is saying this? And which paper he referred to? Then you go to that paper. You go to that paper, and then that really strengthens your knowledge. Well, thank you so much, all of you, for your patient hearing and this. Thank you very much. And a small announcement. This is not marketing, but this is a proud feeling. We already have our presence in Kolhapur and Pune. We are coming out with an IVF unit with Dr. Umarji Hospital in Pune, and we are starting our IVF in Bangalore. Okay, Dr. Richa Pal will be our chief consultant at Bangalore. On 25th of May, we are starting our center in Sunanda IVF will start its branch in Bangalore. So thank you so much, all of you. Thank you.